All right, this is Dr. Schmo from the Functional Neurology Center and the Brain Health Online Summit. And today I'm here with Dr. Russ Hornstein. He's a chiropractor located in Malta, and he's been in practice for 24 years. He is a Logan University graduate, and he's been doing the Carrick Institute functional neurology courses since the very beginning. And today he's going to talk about cervical biomechanics and how it relates to traumatic brain injury, and how we can adjust the cervical spine to improve function and improve people's ability to know where their body is in space. And he's really going to kind of dig into this whole idea of neck integration to how the brain knows where you are in space. So I'm really excited to have you here. So I will let you kind of go after it.
That's great. Thanks a lot, Dr. Schmo, for having me. It's always an honor to speak with you. And yeah, so what we're going to do is we're just going to break down kind of what happens when people have a head injury. And sometimes when you have a head injury, there's also effects in the neck as well. It depends on what kind of injury it happens and the position of the head and the position of the neck in those injuries. But before we get into it too deeply, I want to break down a little bit about what is it that creates an injury, because obviously our bodies are moving in lots of different ways, but some movements cause an injury and some movements don't. So what is it particularly that makes a particular movement an injury? And really what we can break that down to quite simply is the amount of force, or that speed of the rate of change, if you will. So in other words, if someone's moving very quickly and then they stop suddenly, like if you have a car crash, and you stop very quickly, it's that change of your velocity, change of movement from a fast speed to not moving or a slower speed. Or if you're still and then something hits you from behind, again, the same sort of thing. So it's really that rapid change of speed, which is what's causing the injury. So in the brain, that rapid speed of change can damage some of the structures of the brain, because obviously it's many of you know, the brain itself is very soft and is susceptible to these high velocity changes. And in the same respect, our neck responds to high velocity impacts and stretches, but in a slightly different way. So rather than actually damaging the brain tissue, which you would have in a brain injury, when you have a high velocity impact, which is affecting the neck, it affects the muscles around the neck and also sometimes even the joints themselves. So what I wanted to do is first just kind of dig into what is it that's happening. If we break down just a normal sort of motion first, when you were, say, stationary in your car and you want to accelerate from a green light, you put your foot down and the car accelerates. And what ends up happening is your head gets thrown back. We all have that experience. Your head goes back. Your body senses your head being thrown back. And there are reflexes in place that use the sensors in our joints and in the muscles around the joints to sense that sort of stretch of your muscles being stretched as your head goes back. And there's a normal response for those muscles to see how much, to try to measure the load or the stretch of those muscles, and to then respond with an equal and opposite amount of contraction of the muscles to be able to hold your head upright. Because it wouldn't work very well if we put our foot down and every time our head just stuck back and we couldn't lift it up. So this is a normal response, and that works within a certain range. So say, for instance, if you put your foot down really hard and you had a very powerful car, there'd be more of a stretch, but your body would still sense that more stretch and again respond with a stronger contraction. So your body has the ability to measure how much force is being the head or the neck is being exposed to, and then responding with kind of an equal and opposite force to be able to maintain the stability and integrity of the joint and also to hold the head in its position. So that all happens within a certain range of ability. Now, we weren't really designed to be rocketing along highways at 70 miles an hour. And if you have a crash, our body wasn't really designed to withstand that level of force. Yeah. So if you do have that kind of a force, what will happen is there's such a high force that it's not that your body can't necessarily sense it, but it senses a very, very high force. And if it were to try to then respond with a much, much stronger contraction, the muscles could actually tear themselves, or there could be some serious damage, long-term damage in those muscles. So
So Russ, so in those muscles,
yeah,
there's different receptors in the muscle and in the tendon, correct? And then
exactly,
that information is fed into the brain, and that goes into the cerebellum, and then
exactly.
it's fed into the brain stem and up into the brain to allow you to know where your body is in space.
Exactly. Yeah. So that's a great point. And there's a lot in what you said there. Um, we'll break that down. I mean, there's definitely two different types of receptors, as you said, in the muscles
Yeah.
that are sensing the rate of change of stretch and also what we call the load. But what ends up happening is when there's a very, very fast or very, very high velocity of force, that sensation gives a very strong input to the load sensor, which will then use a protective mechanism, so a different mechanism, to then switch that muscle off to try to protect the joint. So we call that resetting the gain of the muscle, or resetting that muscle, which was trying to hold you to a longer length. And in that moment of the impact, that will kind of save us from tearing those muscles apart. It's gonna be that upper threshold of what our body is designed to sense. And if we can't if we can't withstand that force, this protective mechanism is going to save the muscle. It will allow the joint to move more than it could, which in turn could affect the ligaments and even the structures of the joints themselves. Mm-hmm. But what will happen is you'll be able to maintain the muscle itself. However, afterwards, that lengthening of the muscle, that resetting of the muscle will actually remain. So what can happen is after a whiplash, people often see that they feel fine after the whiplash, but then the next day everything tightens up because the muscles that were stretched were actually stabilizing the neck. So with those stabilizing muscles now switched off, the person is lacking the stability of their neck, and their body senses it, and then it will start tightening up other muscles to try to preserve and hold the joint together. And this really messes with that whole mechanism that you're talking about with the cerebellum and your brainstem, and how all this information is coming together, because those sensors in the joints are going to be working a little bit differently as well when the muscles around the joints aren't holding the joint together.
So I mean, so you're saying that, with these injuries, not only can you have structural damage, so you can have an issue actually physically with the neck and pain receptors and feedback going into the brain, but you can also have trauma neurologically, so centrally to, say, like the cerebellum or the vestibular system or different regions in the brain. So you can have both ways.
Yeah, absolutely.
Yeah, you can have a structural injury and a brain injury. And with what we do in functional neurology and chiropractic is we need to address both, correct?
Absolutely, yeah, most definitely. So one of the things, I mean, obviously, for anyone that's been to yourself or another functional neurologist, we do lots of tests. So we're testing the eyes, and then we're testing the eyes when we're moving the head, and then we're moving the body, and we're doing all these different tests because we want to see how the brain is putting all its information together to know where it is. So if any of these systems that are putting that information together or perceiving where the joint is are not giving good information, then our body isn't going to be able to respond as appropriately. So we'll see, strange functions happening. Where, say, for instance, we ask someone to touch their finger to their nose and they miss. There's a reason. They're not able to calculate where their nose is, and there's obviously a lot of integrated mechanisms for how that happens. So I think it might be interesting to look at what it is that's happening when those muscles go out of balance. So when we have this sort of injury and these muscles get stretched on one side of the joint, if those are muscles that are trying to hold the joint together and they're stretched, they're not going to be able to hold the joint together as effectively. So what your body will do is create other muscles to be tight on that same side to try to stabilize. But also every muscle has its own antagonist. So for that particular stabilizing muscle, which has been overstretched, its antagonist is now actually going to be a bit shorter. So what we'll find is that when we try to bring the joint back towards a sort of neutral position, the muscles being out of balance, we're actually going to find resistance of the joint actually even coming back to neutral. So it's really important when we're palpating the joints post-injury to figure out exactly what is the balance of those muscles around the joints.
So with your type of palpation and your technique with adjusting the cervical spine, what you're trying to basically feel is, are you able to go back to neutral? Is there resistance in going back to a center position?
Yeah, that's exactly what it is. So obviously there's lots of muscles around the joints. There's what we call intrinsic muscles, the deepest muscles that are really holding the joints together and guiding the normal motion of the joint. And then there's what we call extrinsic muscles, which are the ones that are the prime movers of the joints. So if there's an imbalance of those intrinsic muscles, what you'll find is that the joint won't be moving as ideally as it should. So
Yeah.
when there's a balance of the muscles, the sort of rotational point of the joint will be exactly where it should be. But if there's a muscle that's tight on one side of the joint, what will happen is the joint will rotate in a way which is not appropriate. So the axis of rotation will shift towards where that tension is.
Okay.
So when we're examining the joint, we want to see how is that joint moving. And rather than just, if we see that it's moving too much this way and not enough the other way, it might not be appropriate just to try to turn it the other way. What we want to do is figure out where there's resistance of that joint to come back to a neutral position. Because what the joint isn't trying to do is to try to move all the way to its end range. You know, a lot of times when we're assessing joints, we see, oh, well, it's really restricted this end range. It's not necessarily that we need to work further to that end range. The better question to ask is, how capable is this joint of getting back to its neutral or most stable position?
Okay.
So that's really what we're doing. So we'll put the head in different positions and then palpate back towards the neutral position, and then we'll find out where it's most restricted.
Okay. So then with your adjustment, you're trying to induce a motion that would bring the joint back to neutral. And when the joint's back into neutral, then there's going to be appropriate gain and sensitivity of muscle spindles and all those intrinsic muscles. And then that's going to give your brain a good perception of where your neck is in space in relation to where the rest of your body is in space in relation to your head. And
exactly.
You know, one of the things that I saw is I've had multiple, you felt my neck before. Like,
yeah, exactly.
had, multiple whiplash, concussion injuries. And what I would see is after I would get adjusted, I wouldn't feel good. And, it took me a long time to try and, find somebody that could adjust my neck in a way that would allow me to kind of integrate things more appropriately with my position sensors and my vestibular system. And, I would fly to Amsterdam and honestly fly to Malta to come get adjusted by you. And honestly saw some major improvements with the types of technique that you were using on me. So I think it's a different way of approaching it that people haven't really explained before. And I really like the way that you explain it.
Yeah, okay, great. Well, we can go into that then. So thank you for the compliment, by the way. So it is different in the sense that what a lot of adjusting is doing is taking the joint from sort of a one position and moving it all the way to the end range. And obviously we'll get a very big stretch when we do that. But when we're doing that, we're moving the joint past its sort of normal range of motion, what we call the paraphysiologic space. That's putting a lot of tissues under stretch. And when we apply that high velocity force to the joint, we're going to be stretching all the muscles that we're stretching before the adjustment are going to be stretched with that impulse of the adjustment. So what we're going to be doing is, if we're stretching lots of muscles, we're going to be basically reducing the tension of lots of muscles. And also, if we're adjusting several joints at one time, we're going to be reducing the tension of lots of muscles and lots of joints. So that might not always be appropriate. And certainly in cases where someone has a little bit of instability in the way their brain is functioning, if they've had some traumatic brain injury, it's quite important to try to be as precise as possible, because when we do that stretch, it is a very powerful tool. Now, it's exactly the same stretch I was explaining in the injury, except rather than being at a high velocity and damaging the joint, we're doing it in a very precise way in most chiropractic techniques. So, it's not going to injure you, but we are using that mechanism of resetting the gain or lengthening those muscles. And if we're doing it to a lot of different muscle groups, we might be turning down too much tension in the spine and affecting some of the stability over several segments. So one of the key tenets of adjusting to neutral is that it's very, very precise. uh, you know, very, you know, we all like it when we hear lots of cracks in our neck,
Yeah.
but very often with this adjustment, you'll just hear one or two because we're being very specific. It's a particular muscle and a particular joint. So, and the way that we're adjusting is it requires a very specific setup to find where the muscle tension is. And it's a very, very precise stretch, which is a vector stretch. So it's just a straight line stretch, which is taking the joint back towards a neutral position. So in other words, what we're doing is rather than taking a joint and bending it all the way to the side and then bending or twisting it more, we're feeling exactly where that joint is a little bit off neutral, and we're taking it from that position and bringing it back to a neutral position.
Okay.
So the adjustment itself is finishing at a neutral position, and in doing so, we know in doing that we can actually change the length of these muscles appropriately, so that we're going to feel that the stabilizing muscles are going to work more in concert with one another. So, like literally right after adjusting to neutral, the neck will be more stable. You'll feel it much more stable straight away, rather than relaxing a lot of muscles and then seeing how your body responds to it. We know what the response is immediately.
So with your adjusting, I mean, do you have indicators that you assess prior to adjusting and then indicators that you assess like post adjustment?
Oh yeah,
Are you looking at things neurologically?
absolutely. Yeah, most definitely. I mean, we can use a lot of different neurological testing, but that's a great question because one of the main things that we use is looking at how this information is being integrated with other information. So what I mean by that is that the way that our brain knows where we are in space is by what we see, by what our vestibular apparatus is sensing in our inner ear, and also from the proprioceptors, primarily in our neck. So in other words, our brain is drawing a picture of where we are and which way we're moving according to how these sensors in our vision, our inner ear, and in our neck are all putting that information together. So I like to use tests where we're testing the eye motion, or we're testing the eye motion and the head motion together.
Yeah.
So if I'm looking at someone's eyes and I move their head, their brain is getting information from their vestibular system, which is sensing that motion of their head. They're also getting proprioceptive information from their neck, and they're also getting information from their vision. So I'm giving them tasks, like I might say, look at my thumb and stay focused on my thumb as we move their head. So what their brain has to do is to put together that visual information with the vestibular information with the proprioceptive information. And if it's able to do all that well, then I should see good function.
Yeah.
But if there's something wrong with the proprioceptive system where the joints aren't moving the way they're supposed to, so in other words, we're getting what we call errors or aberrant or the wrong kind of information. So the joint is moving badly, your neck is moving to the left. A lot of the joints are saying, yes, your neck moved to the left, but then you have a few joints that are moving in a weird way. It's going to give this kind of confusing information to your brain about where your neck is. So as your brain tries to assemble all this information into an integrated perspective of where you are, it's going to start to have some failures. So we'll see, oh wait, when I have you look up and to the left, your eyes fall apart. But interesting, when I move your head in that direction, it's a bit restricted here as well. So very often we'll find parallels between eye motions and neck motions, so that the problems in the neck motions, in particular vectors of neck motions, or say for instance, if their head is down to the right, we try to bring it back towards neutral. If I feel resistance in that, but at the same time, their eyes are faulty in that same vector, then what I'll do is I'll fix the neck and see if the eyes are resolved.
Okay.
Because a lot of times we see problems with the eyes and we think, well, this is an eye problem. We need to do lots of eye exercises to try to fix this, which may work, but it's not going to resolve that proprioceptive problem.
Yeah.
So by finding a very precise and specific way of addressing these proprioceptive issues, it's giving more clear information to the brain about where that joint is, okay? And you're having fewer errors. So all of that information can be integrated much better. So very often before I were to think that there's an eye problem or a vestibular problem, in the inner ear, I'll check the proprioceptive information coming from the neck. So
Beautiful.
if there's something there, it's always good to fix that first.
Yeah, and I've seen with many of the cases that have, had, vision rehab and vestibular rehabilitation and, they're doing balance work, that there still is a cervical spine component, but
Yeah, exactly.
it's not just a biomechanical aspect. It is a joint position sensing error and how that information is
Exactly.
being fed into the brain. And
Mhm.
you can have horrific visual and vestibular symptoms from having just an issue with your neck, right? So
Exactly. Yeah,
that
absolutely.
and your visual system can be fine, and your vestibular system can be fine, but you have those symptoms, but that information from the neck that feeds into the brain, into the brainstem, where there's
Absolutely.
multi-sensory integration that's occurring.
Yeah,
And all of these systems can be totally fine, but they're just not being integrated together. And there's a massive amount of information that comes from your neck that
exactly.
bombards your cerebellum that goes into the brainstem and up into an area in the midbrain called the superior colliculus. And
Exactly.
then
Yeah,
that allows you to have these maps of where your body is in space, how it feeds into the parietal lobe. So I think
exactly.
addressing cervical spine proprioception and where your brain perceives your neck to be in space is huge for
Yeah.
improving obviously headaches and dizziness and lightheadedness and fatigue. And a lot of patients will have normal visual assessment, normal P100 testing. All their visual pathways are fine. Their
Right.
vestibular testing is fine. Their inner ear is fine. They don't have
Right.
nystagmus, but yet they have all of these horrific visual vestibular symptoms. And it
Exactly.
really is coming from the neck information getting fed into the cerebellum.
Yeah, absolutely. I mean, you're really well set up. I know what you have in your clinic. You've showed me, and you're very well set up to be able to differentiate between all that. You have that an amazing resource of equipment to do that,
Yeah.
and so it's to be able to, as functional neurologists, to figure out really where that problem is really the key to that first level of success. So
Yeah.
we have to take the right first step. And once we can take that right first step and we can start to see the system changing, then we know we're on the right track. And also, like you said before, all of this information is being integrated in the midbrain. These are old pathways. These are something that is a very, very old part of the brain. And that older part of the brain is really feeding the information, well, really creating the maps, which are then your brain is using to be able to coordinate motions. So
Yeah.
if your brain can't put together an image of where you are in space because there's something proprioceptively wrong, maybe not even just in the neck, it could be somewhere else as well. But if there's something that's giving bad information to your brain about where your joints are, that's going to throw off these cortical maps. So when your brain is trying to decide how to move, we're going to see failures in these movements.
Yeah.
So, this is kind of like the groundwork. It's like level one of what we're trying to resolve. We need to make sure that this system is functioning well, because if it isn't, it's going to have knock-on effects in other systems. So that we don't confuse where the issue is.
Yeah.
It's always a good place to start with this.
So, I mean, possibly somebody could have a change in their brain function from a whiplash injury, and
Yeah,
that could change their mapping. They could develop, say, tightness or posturing in their shoulder. And
yeah,
then that aberrant information from their shoulder, the way that their clavicle is moving, that could
yeah.
send bad feedback into the brain, and that could lead to dizziness.
Yeah, absolutely. Absolutely. I mean, there's tons of scenarios around all that as well. I mean, sometimes when there's something that has caused like an injury we're talking about here, say in the neck or even in the low back, where something has happened which has created an instability in the spine and your body responds by contracting muscles. Very often the muscles that will contract will be flexor muscles for various reasons. I mean, there's also the cortical reasons for it as well. But if you have some other muscles that are tight, as trying to protect the joint, then what will end up happening is those tight muscles are going to affect other joints that are affected as well. So in other
Yeah.
words, you might have a problem with an instability in the neck, which is creating a muscular pattern around the shoulders, which is creating a shoulder problem, which could then create,
Yeah.
problems in the kinetic chain of other muscles along that same kinetic chain. So like you're saying, you could have subclavius tension, you could have pec minor tension, which is affecting the shoulder. And then you could also have, biceps or flexor or pronator teres or flexor carpi ulnaris problems causing elbow problems or wrist problems. These are all flexor muscles that could be firing off as a consequence of some other
Yeah.
compensation pattern around the neck.
Yeah.
So
So
it's very, very common. I'll see people come in and I test and I see that, okay, there's something happening in their, say their toes are weak or their hip is weak.
yeah.
But I also see that they're not integrating things because there's probably some poor proprioceptive feedback from their neck. We resolve their neck and suddenly their hip works and the toes are strong. And
Yeah.
they say, well, how are my toes strong when you
Yeah.
just adjusted one thing in my neck? Well, it's because of this connection. It's these kinetic chains. It's the balance of flexors and extensors that are regulated, cortically as well. So, there's a lot to the image. We could definitely go into that in infinite detail, but it really does very often come down to just making sure that we have good stability in those joints.
Do you have just like one simple tool that a patient that might be watching this could use to know if they have an issue with, say, like their neck proprioception? Is there anything that you can think of that they could do at home to?
Yeah. Well, I mean, one of the most common things is that someone will come in and complain saying, well, when I turn my head this way, I feel terrible. I mean, obviously that could be an integrative issue, but things that are associated with head positions, are often, signs that there's something going on there. So are you asking if there's something that they can do themselves,
Yeah.
or?
Is there something that they could just like test themselves at home to
Yeah,
know, is there a issue with my neck, proprioception? Like what could they do at home? Just like something
yeah,
quick that they could do
yeah,
that might tell
absolutely.
them that they have a problem.
So one of the things is that the joints are designed to work in a certain way. So if we try to move the joint in the way that it's designed to move, and we feel a problem in that, then that's probably a pretty good sign. So
Yeah.
I always refer to Stevie Wonder. Stevie Wonder, he's that musician who, when he sings, he swings his head
Right.
back and forth like this.
Yeah.
Well, that particular motion that he does like this is actually what we call the coupled motion of the neck.
Yeah.
So when you laterally flex, you sort of bend your head to one side, and then you let your chin drop to that side, and then you lift your chin and then drop it to the other side and rotate like this. If you're doing that sort of figure eight motion and that feels really nice and smooth, then
Yeah.
your joints are probably working pretty well.
Okay. That's great.
It's a great easy test to do. So
Yeah.
if you can sort of, you don't have to play the piano for this, by the way.
Yeah.
You just have to be able to do the head motion. So put on some Stevie Wonder, see if
Okay.
you can do that motion. And if it feels good and smooth, then it's probably working well. But if you get to a certain point and you feel like something's binding up in there, then it's probably because there's some joint which is a little bit pathomechanical. So yeah, you definitely want to check that out.
That's great.
Cool.
All right. Well, if there's, we're going to wrap up here. So anything else that you would like to add about, what we talked about? I mean, basically we kind of went through, you have these injuries, your neck, your cervical spine, it can't absorb the force correctly. That force goes in and starts to, break down tissue and lead to changes in loading and feedback into the brain. So you can have an issue with the neck, but also have an issue with the feedback that goes into the brain, and areas of the brain might be injured as well.
Yeah,
and then you kind of went into what are normal biomechanics of the cervical spine, and then kind of broke down just some simple things that patients can do to test
yeah.
themselves. So that was great. Is there any other things that you would like to add?
Well, I'd just like to say that as well, the motions of the joints are, like I said, they're very, very precise. And I think that the more we can understand and be able to evaluate how capable that joint is to come back to a stable position,
Okay.
if we can link our therapies towards getting that joint back towards a neutral position, or just even asking that question, why isn't this joint able to get back to a stable position, and align our therapies with that. I've developed this adjusting for that, which
Yeah.
is working very, very well. But if other people can try to find ways to do that specifically, I think we'll start to find more successes in trying to resolve these things. And really, it just takes being precise with our therapies. I was certainly taught in school, this is the way you adjust the neck, and you do it that way. It seems to have good effects. And then I discovered, so I was taught at Logan, so we had what we call diversified adjusting, and there are a whole range of other types of therapies as well. And then I learned Dr. Carrick's coupled motion reduction,
Yeah.
which then just massively boosted my results, because rather than having to treat someone 20 or 25 times to try to see results, within, 3, 4, 5 visits, the joints are working very, very well.
Beautiful.
And that worked very well for many years. But then I thought, well, maybe there's a way that we can do this just a little bit better. So I've made a modification, which is kind of in between diversified and coupled motion, in the sense it's still coupled motion, but really the only thing we're doing is just bring that joint back to a neutral position. And then again, I saw the results come up again. So
So
yeah,
where can people find your videos? I mean, I know you have a group on Facebook. I think is it Adjusting to Neutral? Is that what it is?
Yeah, it's Adjusting to Neutral. So just ask to join the group, and we'll obviously, all the chiropractors and therapists doing manipulations are welcome. And I also have a YouTube channel. You just type in Russ Hornstein, and you see a bunch of videos that are more for sort of public consumption. So depending on who you are, there's different resources there. So, and obviously I'm always open to people reaching out and getting in touch. So yeah, so I'm very open to people with questions. So just fire them off.
All right. Well, thanks, Russ. That was great. I think that information will really, really help patients. It will help providers have a better idea of, what they can do to help their patients better. So that was awesome. And we're going to sign off. Thank you.
Great. Okay. All right. Thanks so much for having me. Okay. Take care. All right. Bye now. Bye-bye.